Okay, so this presentation is about whether it's possible to modify the Start Back screening tool for use with patients with other musculoskeletal conditions. Many of you will probably already be aware of the Start Back tool. Some of you might not. It's a stratification method to support GP decision making by matching patients to targeted treatment based on prognostic information. It's an approach that has high quality evidence, including a randomized control trial, and we know that the tool itself has predictive validity in primary care. But the question here, many people are asking us, is what happens if you use Start Back for other musculoskeletal conditions? Is it predictive for shoulder pain, for knee pain, for neck pain? It is true that the epidemiology evidence seems to suggest that prognostic factors are very similar across different musculoskeletal conditions. And we know that GPs tell us that prognostic information is really important, not just for back pain, but for some of these other conditions as well. We don't actually know yet whether it's effective to stratify care for these other conditions, but we need to start by looking at the tool. So the aim of this study was just to test whether a modified Start Back tool, just tweaking the items to make them generic, was that going to be something that was useful to use in a broader group of musculoskeletal conditions? So what we were doing was taking the original tool and then just tweaking each of the items to make them more generic. So in terms of the methods, what we did here is we took this generic modified version of the Start Back tool and we embedded it into two prospective data sets, the PhysioDirect trial and in the SAMBA study, which is a prospective cohort in musculoskeletal interface services. And there were two things that we needed to do. Firstly, we needed to classify people as having different primary musculoskeletal problems. So was it a back, a neck, a shoulder, a knee, etc. And did they have a good or a poor outcome at follow-up? And here we used the 6-month physical component scale of the SF36. And then we were just using area under the curve and sensitivity and specificity to look at, for each region, how was this modified tool performing in terms of its predictive validity, and also to try and look at were the cut-offs equal, regardless of whether it was a knee, a multi-site problem, a shoulder problem, were we seeing that the cut-offs were appropriate and consistent across those different areas. So what did we find? This is the data from the PhysioDirect study. You can see in the figure here. The results demonstrated that actually the areas under the curve were very similar across patients with different musculoskeletal conditions. If anything, back pain was the least, and it was even better for necks and shoulders and other common conditions, which was all very positive. But on the negative, when we look more closely at the sensitivity and specificity for each cutoff point, what we found was there wasn't a consistency. And particularly, if you can imagine some of the questions like people struggling with walking, that's not going to equally affect a shoulder problem as it's going to affect someone with a lower limb problem or a spinal problem. And so we were getting a difference in scores, and that meant the cut-offs weren't working consistently across different regional pains. Now, the findings were replicated in the SAMBA data study as well, and were very similar. So our conclusion from this work was, firstly, the predictors that we have for low back pain in our original Start Back tool, they can be tweaked and they can be made generic, and that does give you a predictive score among patients with other common musculoskeletal conditions. But because some of those questions are very specific in their nature, for example with the walking, then that meant that the optimal cut-offs were not identical across the different conditions. So we're now therefore developing and validating a new tool. We've just recruited 1,800 patients to see if we can get a set of generic items that will work consistently to stratify patients with the 5 most common musculoskeletal conditions seen in general practice, but importantly using the same cut-offs so that they're consistent across the different conditions. Thank you very much.
Any questions for Jonathan? Can I ask
So do you think the Start Back tool is specific for musculoskeletal problems?
Do I think it's specific?
For musculoskeletal problems, or can you generalise it to other chronic conditions?
Oh, well, That's a good question. The only place where it's been used more generically so far has been in a children's cohort, where they used it in a pain cohort with a range of different conditions, including respiratory problems and cardiovascular problems, and they found it was predictive, but they'd already modified it slightly. But yes, it was predictive in a broader range. I think, though, what we need to do is, clearly we've got here something with StartBack that's designed for back pain, and what we're wanting to do is to get something that will work across musculoskeletal. And while it might be predictive, if you just take the back pain ones, you do get this problem because some of the questions are very specific, that you don't then get consistency in terms of cut-offs. So, yeah, I think we can do a better job of coming up with some items, particularly the function items, which are more generic in their nature.
Because there's no talking about more broadly things. There was another tool, I can't remember what it was, but they were looking at people's life expectancy, and with a really simple set of questions. And the main questions were, are you already ill? That was the main thing that seemed to predict whether people were going to have reduced life expectancy. And then it was really simple things like gait speed. So it's perhaps really simple things can answer a whole lot of questions.
Yeah, maybe. We need to test it, I guess, and we haven't done.
Can I ask Jonathan, do GPs really want another risk stratification tool?
Ooh,
If we look around all the different presentations at SAPC over the next couple of days, we're going to see risk stratification tools for almost everything you could imagine. And actually, are they going to get used? Are they going to make a difference?
Well, it was interesting. I mean, Simon Stevens, I was just saying to the Dean, it seems like he doesn't like checklists. But I think what we would argue, this is about supporting GP decision. This isn't about checklists. This is about pattern recognition, identifying those high-risk patients who have complex needs. And so we need to think carefully about what we're doing so that it isn't just checklists, but where there's strong prognostic information that really can help a GP in their decision making. And if we can find ways of doing that, I think there is a sort of a compromise somewhere in between where we support GPs in their decision making without turning them into sort of checklist robots. And that's the challenge we've got to find.
Sorry.
Sorry, Rose Galvin from the University of Limerick. I'm a physiotherapist also, but one of the things that I think about clinical prediction rules in general is that we're deriving rules and we're, I suppose, narrowly validating rules, but very few rules. Now, the StartBack isn't an example, but have undergone impact analysis, and I think that's where clinicians, there are so many rules presented with small patient numbers. I welcome your large patient data because physiotherapy traditionally don't have those large databases of patients, so I think with robust data like that there will be more methodologically sound than just the smaller numbers that people derive and narrowly validate. So I think it's actually, it could be something very generic, very simple, like
We've got to use the evidence to drive what we do.
Yeah.
Sorry, it's just it's not another question. I was just wondering how whether GPs and physios need a tool to predict whether someone's going to do well or not.
I don't think they necessarily do, but do we get better outcomes when we compare usual care to when they have stratified care? And that's what the trials have done, and that's where we've seen improvements, significant improvements across the board.
Those three strata, though, if clinicians, experienced clinicians, could they just predict who's going to do it without using the tool?
I think they can, and I think Christian's work has shown that clinicians have got a fairly good sense of who's got a poor prognosis.
The better people are, it's a nice way to end the session, the best people to ask are the patients. Patients predicting their own outcome actually is more accurate than most of these risk stratification models that we use together, because there's something intrinsically about knowing your general state of health, and I think these are these very generic issues that people pick up on that perform very well. Thank you, Jonathan.
Great. Thank you.